We're going to talk about BCG unresponsive patient and optimal therapy for BCG unresponsive high-risk non-muscle invasive bladder cancer. BCG is standard of care. Most intermediate patient will get it, or high-risk patient will be recommended. It is superior to chemotherapy in the high-risk patient. The data is supported by large randomized trial, as well as some meta-analysis. It is endorsed by the guidelines. Better results with longer therapy, including maintenance therapy. This study will be debated a little bit later. But the SWOG 507 was the study that looked at the value of 6 weeks as compared to longer maintenance essentially every 6 months after you get going with 3 installation every 6 months, and showed clearly that there was benefit to the longer duration by about 20% in terms of recurrence-free survival. And then it was durable out to about 5 years, so that kind of set the stage. But the problem is not everybody responds to BCG. Some patients will recur, and in fact, maybe up to half of the patients may. If you follow them long enough and monitor them, and you only salvage a certain percentage, maybe a third of them, with additional BCG therapy. The FDA, in conjunction with several stakeholders in 2018, published a guideline on what truly defined the BCG unresponsive disease. They defined it where what is adequate BCG is you get a last 5 plus 2, so the round 1 you get 5 to 6, and around 2 you get 2 of 6. If you're gonna do second induction, 2 of 3. If you're gonna do second maintenance, so you have to at least 5 plus 2. And then they have these 3 different categories that defines unresponsive. So if you got adequate BCG, if you got an adequate BCG, which is at 5 plus 2, and you have a CIS more than a year, the last BCG, then you considered unresponsive, so that only 1 year. If you have adequate BCG again, 5 plus 2, and you have a TA tumors within 6 months of your last BCG, you are considered unresponsive. And here's the other special one: if you have a high-grade T1 after induction. BCG, you still have a high-grade T1 at the 3 months, you are considered unresponsive. So again, that reflect high-risk patient there. So now that we've kind of defined some of these definitions, if you have BCG unresponsive disease, you should get your blood out. But we all know that a lot of patients are unwilling to do that. A lot of patients aren't fit enough to tolerate the surgery. So what do we do to those patients? If you failed BCG twice again, 5 plus 2 is what you define it to find that. If you don't want to get cystectomy, you're unwilling or unfit to do it, then what do you do? There is 2 options. If you have one available, you use Pembrolizumab, or you do some type of intravesical therapy. Depending on the approach, there are intravesical therapy and systemic therapy. Agents available for intravesical therapy include chemotherapeutic agents and viral genes. For the systemic therapy include immune checkpoint inhibitor. Valrubicin has its approval since 2000, but initially it was short-term in about 6 months. They had about a 21% complete response rate. As patient was followed out longer through at least with 6 weeks of the therapy in the response vein. Most people would probably do this study with maintenance chemotherapy if they were doing it today. And the other problem with this is very costly. Gemcitabine data for BCG unresponsive patient at this pace. 2 studies done by Southwest Oncology. And what was interesting was they used gemcitabine not just 6 weeks, but they used a monthly maintenance. Gemcitabine had a 12-month RFS of 28% and 24 months RFS of 21%. Docetaxel has a 12-month RFS of 40%. Docetaxel has a study with 54 patients, looking at it as an option. So that may be something you would use. We tend to use more gemcitabine, but there is no reason you couldn't. Paclitaxel has a 12-month RFS of 36%. But you could use Paclitaxel to simulate somewhere in the 25 to 30% range for disease-free status. In some of these studies, go out beyond a year, so that's not bad for some of these salvage chemos. Agents used for the Valrubicin therapy are CG00700 and Instiladrin. CG00700 is an oncolytic adenovirus that expresses on GM-CSF transgene and selectively replicated in retinoblastoma deficient cell. The CG00700 regimen has a CR of 48.6% at a median period of 10.4 months. Instiladrin is a replication deficient adenovirus that expressed on IFNA transgenes. Instiladrin was reported to have a 12-month RFS at 24.3% in a multicenter phase 2 trial. Agents used in systemic therapy include immune checkpoint inhibitors. The PD-1 inhibitor Pembrolizumab has gained FDA approval for the treatment of patients with BCG unresponsive high-risk non-muscle invasive cancer with CIS who are ineligible for the decline cystectomy. This approval was based on the result of the KEYNOTE-057 phase 2 trial. At the median follow-up was duration of 28 months, median CR duration of 16.2 months, and 12 months CR rate was 23.6%. Patients who are unsure for surgery or who do not want radical cystectomy may be treated with intravesical chemotherapy or systemic therapy. For the BCG unresponsive patients, there are various treatment options, including intravesical chemotherapy, viral agent, and immune checkpoint inhibitor systemic therapy. Recently, several treatment methods have shown great promise in treating BCG unresponsive. Thank you.